this is part 2, and we treated the left femur in anterior glide for 5 minutes, and I haven't tested it yet, so we will now. And I see freer patellar mobility inferiorly, laterally, medial. When I lift, there's the subtlest lift mobility. Can you feel that?
Mm-hmm. Yes.
So now I'm going to do a posterior glide load. And so we've seen movement throughout the leg. And now I'm going to use approximately the same amount of force to test force transmission in the loaded position. There it is. And there is adequate recoil. So this knee, at least in terms of patellar mobility and in terms of posterior glide of the distal femur, is much more similar to the opposite side. And what I'm going to do now is test knee extension. I'm just simply going to lift. Your thoughts? Oh, don't, just relax. Let me do this.
It feels like there's less than what it was before.
Interesting. Very good. That's what I feel. So let's have you stand up and let's have you do a couple of squats and let us know. So doing the same way you did before.
No, there's really not that much of, not nearly, I don't really feel anything.
Good.
I do hear a slight pop in the knee.
Yeah.
As I come up.
Very good.
But I've always had that.
Sure.
So I don't know if that's just kind of a common thing.
Got it. Well, we did teach you how to treat it yourself down the road if you should need it, but I don't think you will.
Okay.
My experience has been that this correction of normative mobility tends to be very lasting, but if it should ever recur, at least you know how to do it. And after we film, we'll talk about how much weight you were using and the position of the squatting, and see if we can modify that in the goals of prevention.
Okay.
But it's a pattern I see somewhat often. I'm not aware of published research on this entity, and it would be nice to have some published research to encourage it to be taught and the treatment to be utilized in the clinic and to be taught in physical therapy schools. So we'll stop filming. Thank you for letting us film.
Thank you.